Good morning to everyone who's present here. Though we have a very thin gathering, but we like to start on time. So this AIOC, we are trying to present something called not to miss Goofy for Pluto. So there are a lot of macular disorders where we find that mimickers masquerade the illness and lead to wrong diagnosis as well as futile treatments. So we'll try to answer a few of these pertinent questions today, and let's take it from here. Without wasting time ado, I will start with the first presentation. It is about inflammatory CNVMs. The presentation was by Colonel Ashok from Armed Forces Medical College, and I'll be presenting on his behalf. Very good morning. So we'll be talking about choroidal neovascularizations, which we all know are the growth of choroidal capillaries through a break in Bruch membrane under the RP or the neurosensory retina, classified as type 1 and 2 respectively. So a wound healing process after a break occurs in the Bruch membrane is what is responsible for the occurrence of a choroidal neovascular membrane, and they can be degenerative in elderly people, while in the younger population they are mostly either associated with myopia or with inflammation. Rarely we see post-traumatic or angioid streak associated CNVMs. Now, the inflammatory CNVMs are also a very important part of the milieu of patients which we see in armed forces, especially we deal with a younger population. They are sight-threatening to the patient as well as lead to loss of productivity to a great extent. So talking about the non-infectious uveitis which have been reported to be associated with inflammatory CNVMs, we have most importantly multifocal choroiditis and punctate inner choroidopathy. Both of them, to a tune of 30 to 40% cases over the lifetime of the patient, have been associated with some form of foveal or extrafoveal CNVMs. The list also includes diseases like AMPPE, birdshot chorioretinitis, and MUDs. Talking about VKH, close to about 10% cases of VKH over the lifetime will develop choroidal neovascular membranes. In cases of panuveitis, Behçet and sarcoidosis both have been reported to be associated with CNVMs. Talking about the miscellaneous causes, the idiopathic panuveitis again remains an important cause. In our country, nothing can go without the discussion of tuberculosis, and post-tubercular CNVMs form about 10 to 25% cases, while in the Latin American region, toxoplasma forms a major component. We should be aware that in younger population, when we are dealing with foveal toxoplasmosis, CNVMs are bound to occur at some point of time, and therefore in these cases we have to be a little careful. So the risk has been reported to be about 2% in a cross-sectional study. However, when we compare the causation of this disease, it appears that in almost all cases of choroiditis, the pathway for CNVM has already been created, and it is just a matter of time when these people will throw up the disease. So they have to be under continuous monitoring. VEGF plays a major role in the pathogenesis and also remains the key place where we are able to target this disease. The pathogenesis includes the major role played by tumor necrosis factor alpha, interleukin 1, nitric oxide, and transforming growth factor beta. The clinical presentation is that of metamorphopsia in a patient who till now was only complaining about diminution of vision. So an alteration in the symptomatology of the patient is the first pointer, and dilated fundus evaluation where we are able to see a CNVM with an associated hemorrhage is usually a giveaway. Now coming to the diagnostic modalities, this is the classic FA where we can see early hyperfluorescence in the choroidal phase itself in a pre-existing choroiditis patient. Now this has been reported by the team at PGI about tubercular serpiginous-like choroiditis associated with CNVMs, and ICGA has been the baseline investigation in most of these cases. On ICGA, we can see that as the late phase appears, the CNVM becomes more prominent. Now, ICG helps, but OCT remains the backbone of our clinical screening of these particular patient. And these features, whenever they are present, especially when we see any amount of subretinal or intraretinal fluid, leads us to a suspicion of CNVM. Now, in this case, the classical pitchfork sign could be seen, and this is a tuberculosis associated CNVM. The arrival of OCT angiography has solved this mystery to a great extent, where we are now able to delineate a choroidal neovascularization over the choroiditis scar. And here we can see that either it can be in the classical C-fan configuration, mostly peripapillary in origin, or it can be in the medusa head pattern, which is commoner in the foveal region. Now, this is a case of multifocal choroiditis, where we can see that a CNV has popped it in the frame on the top, and after administration of ranibizumab, the CNV has resolved, the IRF has disappeared, the patient's vision improved substantially. Now, the same thing when we see on an OCT angiography, where we can see the entire branching vascular network, it has shrunk over a period of time after administration of anti-VEGF, and this gives resilience to our diagnosis that yes, the diagnosis of inflammatory CNVM are correct. So OCT angiography has proven superior to FA, ICG and OCT in most of the studies. So whenever you find this complicated case of inflammation of the posterior uveal tract associated with CNVM, don't shy away from ordering an OCT angiography. Also, some role is played by autofluorescence, and we can see this classical appearance where we find that the CNV becomes a hyper ring associated with the hypo surrounding. The differential features between the AMD and the inflammatory CNVM or AF have been described. For the sake of time, I'll skip through the treatment modalities, but the baseline remains that we have to control the inflammation and the CNVM using a combination of anti-VEGF and steroids. Thank you so much. Any questions, please?
Yeah, please.
Please.
In presence of vitritis, I fear of giving anti-VEGF. Can we give, because I have seen one of my patients having CNVM.
Yes.
It is posterior.
So that is one place where we definitely recommend a combination of steroids and anti-VEGF. Though it is being frowned upon by most people that why you are giving an Ozurdex and any of the anti-VEGF at the same time. But this is the classical situation where you will be able to control the inflammation. With the control of the inflammation, the steroid also has an anti-angiogenic role. So even if you give a steroid alone, it might help in resolving the CNVM. But if you add up any of the anti-VEGF, barring say something like brolucizumab, it is a wise option.
Also, the challenge which comes is with documentation with OCT, it becomes difficult because media at times is not clear.
Very true, and that is why the role of ICGA, because ICGA is able to permeate through most of the media haze of vitritis, as well as if you have a overlying blood on top of the retina, the ICGA can see through it. So that is why now it is resurging back as a very important modality.
But challenge is the availability.
Yeah,
Availability.
that is the thing.
We don't have OCTA also. So just started with.
Totally agreed. So that is why I say that when we have these complex cases, these are 2% of our entire clientele of CNVMs, when they present to us, we should not shy away from a referral, because otherwise we end up burning our fingers with these cases. I think for the paucity of time, I'll invite the next speaker. I'll like to introduce Professor Harsh Lanka. He is from INHS Ashwini, and he'll be speaking to us today about CSCR.
Thank you, sir, and good morning to the audience. I'll be presenting on behalf of my colleague regarding certain series of cases of actually not CSCR but subretinal fluid spectrum of cases. So this is a standard classical CSCR and various modalities of imaging. Just to recapitulate what we are dealing with. So first of all, we talk of a case in which a 31-year-old young person, which 3 to 4 week of history of blurred vision, uh, was treated with tear substitutes as computer vision syndrome, MGD, and that kind of spectrum of disorders. However, later on, it's only during his fourth visit that his fundus was evaluated, and this was the picture. Now, this is the standard young person presenting with subtle diminution of vision and metamorphopsia, CSR. But why did we present this case? Because fundus was not seen in this case. It's only on third or fourth visit the patient is actually being seen. Even non-mydriatic fundus was not seen in this case. So later on, he was we took help from our psychiatric colleagues, and he was managed as a case of CSR. Moving on. So now there is a other spectrum of cases in which it may not be CSR, but it is being treated just as CSR because there is some subretinal fluid. So in this case, we have a 23-year-old lady presenting it again, subtle definition of vision in unilaterally. And since the vision was okay, she was just being corrected with minor correction in spectacles. And only later again also in these cases was the fundus seen. And here we see this picture, and therefore toxoplasma was assay was done, and later on it was proven and it treated with clindamycin or Ozurdex. So again, akin to previous case, fundus evaluation is done only during later visits, just because she was young. Again, we have a 22-year-old lady presenting with color vision deformity during her screening evaluation for occupational entry to a professional course. In this case, screening for military recruitment, wherein she was found to have color vision defect, and when the fundus was seen, this was the picture, and based on the morphology we can see the RPE defects, and this was diagnosed as a case of cone dystrophy. And later on she was counseled, because in future she needs to bear kids and what is the prognosis of children and all, and of course she was counseled on preserving her sight using UV protection. Again, a 16-year-old girl who was aspiring competitive swimmer, who presented with moderate diminution of vision in one eye and treated as anterior uveitis with unexplained vision loss, and then again found to have inflammatory cause, and later on it was found out that it was a CNVM and not just a subretinal fluid of some cause. So what was missed in all three cases was the fact that they were young ladies and not men. So it is seen that this simple fact is being forgotten by people who are forgetting the epidemiology of CSCR, that it is only men who are generally predisposed to these cases, and also that even in subtle diminution of cases, in cases with subtle diminution of vision, the ophthalmologist should insist on carrying out color vision checks and contrast sensitivity and non-mydriatic fundus examination. Even in a busy OPD, if the patient is coming for the second time and the patient is worried regarding the symptoms, this should prompt us to consider these tests. Then we have a case of diabetic, who is a young diabetic presenting with subretinal fluid, and we have a OCT scan in this person in different machines. This is the picture which is shown in Cirrus 5000, and here we see the inner retinal thickness to be that is CMT to be 155 microns, whereas if we move to spectralis, it gives a reading of 385. Now if we just rely on technicians who write on without seeing the photograph, we will just rely on technicians who may just give us the CMT and go ahead with it and tend to prognosticate this case, we may fall into a trap. So this is because of segmentation error in this case. whereas wide field OCT gives us a more reliable picture in this case. So what is this we are dealing with? So further angiography and FAF picture gives us there is a hyperfluorescence leakage along the superiotemporal arcade, prompting us that there may be something else, and there is fluid tracking sign. So there is CSCR as well coexisting in this patient who is status post PRP. So this is not just because of the diabetic changes, this is a CSCR in a coexisting in a diabetic. What about this kind of picture in which we are treating the patient as a case of CSR and we find this hyper-reflectivity in the intraretinally? So this is to be taken cognizance of, and we can see there are two strata of fluids. One is SRF, one is below the RP. So this is prompting us to consider other diagnoses such as CNVM. So just because somebody is diagnosed as CSCR, should we not do OCT in every follow-up, that is when we call them for monthly or 3-monthly reviews? The answer is no. We should actually do the OCT every time a patient is visiting us, because some surprise may be lying. Because all said and done, CSCR does also have about 4 to 5% chance of developing CNVMs. Though the clinical clue of developing CNVM such as hemorrhage is very evident, but then by the time the patient is presenting with hemorrhage, it's quite late, and we would rather diagnose it early if the CNV is existing and treat it at the right time. So the OCT clues are important, such as the ones we discussed, which includes intraretinal fluid, any segmentation, and any choroidal thickness associations. We know that in CSCR the choroidal thickness is more compared to other disorders. And also, if there is any occurrence of new hyperfluorescences, as this photo demonstrates, we should also consider CNVM, because we should not confuse this with multifocal CSR, because there may be CNVM happening simultaneously in these cases. So the take-home messages is, in this spectrum of people, of young people presented with subtle diminution of vision and metamorphopsia, we should consider doing color vision and other macular tests such as contrast sensitivity and photo stress test. Fundus evaluation, even if good visual acuity of 6/9 or 6/6 parts is present, we should insist on it, even if in a non-mydriatic setting. Gender should be in our mind, that females are generally not predisposed to CSR, and we should look for OCT clues and acquire scans during reviews. Laterality is also important. If somebody presenting with bilateral symptoms, we should consider systemic conditions or any dystrophies. And all in all, we should summarize it by thinking that SRF in all young individuals is not always CSR. I conclude. Any questions or remarks, please?
I think we'll skip the questions and continue to the next speaker.
Thank you.
The next speaker is Colonel PRADEEP Kumar. He's talking about MACTELs.
A very good morning again. So, talking about Macular telangiectasia, this is an entity which was not very well known about 2 to 3 decades back, but it has now sprung up with the origin of multimodal imaging. So this is the classical case where we see perifoveal change in discolorations may be associated with some amount of pigmentation, and these discrete white discolorations are the beginning of the disease. Now coming to the FFA, how it proceeds, as we look over a period of time, one can see that in the perifoveal region, now we are seeing appearance of these very discrete hyperfluorescences which are not increasing in size over a period of time. So this is what a classical case looks like. And they have these right angle dipping vessels, we have reported this, and they are hypoautofluorescent, which are corresponding to the PEDs when they are associated with macular telangiectasia type 2. Here we can see these classical right angle dipping vessels. And the diagnosis becomes difficult when we have macular telangiectasia occurring in this concurrence with other diseases and other masqueraders which do look like MACTEL. And lastly, any case of macular telangiectasia you have to keep under follow because they can throw a secondary CNVM at any stage. So again, as we say, don't miss the two very similar looking diseases. So it can present with PEDs. Now coming to this particular case, we can see that there are perifoveal telangiectasias in the images on top, and they are associated with these PEDs on the OCT. The classic pointer is the intraretinal cavitation that we see, which gives us a clue that yes, this might be a case of macular telangiectasia. And the catch occurs when we are seeing the OCT angiography and going to the deep capillary plexus. This is the part of OCTA which we should be analyzing carefully to look for the changes of macular telangiectasia. Now, it can be associated with secondary CNVMs. Now, in this particular slide, we can see the feature A shows a very thin layer of hemorrhage, and along that hemorrhage, we can see a disc-shaped area which is greenish to yellowish in color. Now, this is what gives us a clue that even on a detailed fundoscopy, we could have examined that some change towards CNVM has occurred in this pre-existing case of macular telangiectasia on follow-up. Now, when we look at this enlarged image, the diagnosis can become clear even in an OPD without resorting to any of the investigations. And as rightly pointed out by one of our audience, even if you do not have access to these multimodal imaging investigation, you can go ahead and treat these cases clinically. Now, it can also be associated with polypoidal choroidal vasculopathy. We have reported that macular telangiectasia is associated with PPK choroid, and in this particular case, we can see that the STOCT which passed through a polyp-like membrane, and while on the lowermost OCT, we saw this intraretinal pigment plaque. So while the intraretinal pigment plaque is pointing towards macular telangiectasia, in the scan B, we can see something which is now looking like a PCV case. So now we take up a simultaneous FFA and ICGA, and the mystery is resolved. The polyp becomes quite clear, and we treated this case and the vision was restored happily. Now, foveal cavitations in MACTEL have to be balanced against what is happening elsewhere in the entire macula. Now, the blue pointers, they show you a small area where a subretinal fluid accumulation has occurred in the area around the disc, while this kind of intraretinal cavitation looking like a very sweet heart is also apparent. Now, this is the case where we have a central serous chorioretinopathy which is occurring in a pre-existing case of macular telangiectasia, as can be seen quite obviously that right over the papillomacular bundle we had this case. Now, this is another case of CSC with macular telangiectasia. This is what prompted us to look into the spectrum of PK choroid in MACTEL. We have reported it twice, and we have been able to elucidate that PK choroid is also associated with macular telangiectasia. Now, coming to CSC with MACTEL, what one has to be careful of is not to misdiagnose the subretinal fluid as a marker of a CNVM. So, this is a sub-RPE fluid with an intraretinal cavitation without any subretinal fluid. So, should not be treated as a CNV by somebody who's just looking for a hint of fluid anywhere on the OCT. So, not all fluid on an OCT needs to be treated. And sometimes the lesion may not be macular telangiectasia at all. So, now looking at this particular image, one might be prompted to think that yes, I have something underneath the retina, it is associated with some form of fluid, probably this is subretinal fluid and I should treat. But no, in this kind of image, one has to think in terms of AOFVD also. Now, this kind of outer retinal cavitations have again been reported in 2017, and this is a case of solar retinopathy. So whenever you see these dark spaces in an OCT, need not go for the anti-VEGF option directly. Now, further fluid spaces in the retina can occur because of varied causes like acquired retinoschisis, and these acquired retinoschisis can lead to confusion with the diagnosis of macular edema and subretinal fluid. Now, coming to the associations, that this kind of fluid spaces may not be solitary at all, and what we have to look for is the peripheral retina, and sometimes we can pick up diseases like FEVR, so to find out why the disease has occurred. And lastly, we have to look at the choroid and retina junction carefully. I'll summarize by talking about these drusen's which are even being diagnosed as inflammatory or CNVM cause and being treated with intravitreal steroid and anti-VEGF, which we do not feel should be the ideal approach. These giant drusen's were reported by my very dear colleague Dr. Vinod recently, and these are just plain simple vascular shadows and should not be confused for any fluid. The mirror image pattern on an OCT should be alerted for, and one should not confuse these for occurrence of detachment or fluid. So what determines the clinical output of an OCT is the correct indication, an observant eye, and knowledge of the interpretation which we see. And lastly, carry on with the Gauss method, that whenever you are not able to append the diagnosis to a particular scenario, keep it in a file, let it simmer for another 3-6 months, collect 5-6 such new cases, and probably you will be able to report a new disease entity. Thank you so much. We will be taking questions at the end for the sake of keeping in time. Now I will kindly like to welcome Professor Raji. Ma'am is joining us from Command Hospital, Lucknow, and she'll be speaking today about Best disease.
Good morning to all of you. I'll be talking about best disease and adult onset vitiligo macular disorders. We don't know why these disorders have some affinity towards macula. It may be because of its anatomical structure or the composition of the choriocapillaries and the type of blood flow it has, and maybe this area is exposed to more light compared to the other part of the retina. So when a patient presents with, like already the previous speakers have spoken, that in the OPD they will be having mild blurring of vision. We may just do a refraction and send them back without having a look at the retina. Even that is why the importance of at least undilated fundus examination of a screening of the disc and macula is very important, whoever comes to your OPD, so that we don't miss out on these disorders. So the patient comes with mild diminution of vision, and the examination is showing some mild changes in the macula. So we will just leave it like that. It may be, just nothing very significant in this patient. But when you go into the detail, then she might or he will say that there is a family history, one of his relative or mother, father, somebody is diagnosed as age-related macular degeneration, taking treatment for that. So then that will be a stimulus for you to think, is this patient having something else? Because just because of one mutation in a gene, it can cause so many different patterns of disease, ranging from retinitis pigmentosa on one side to the macular dystrophy in the other end. So these are autosomal dominant disorders, and as I all said, there will be, when you have this puzzling fundus pictures, you should always go into a detailed history taking. But other things which should be kept in mind is, we have to rule out any kind of drug toxicity. That's why again the history taking is important. History of any infections like toxoplasma and all, they are already spoken, and autoimmune disorders. That also we have to rule out, and sometimes even multifocal choroiditis can have this kind of a presentation. So let's talk about best macular dystrophy. There are more than 200 mutations which have been described in that, and it collectively known as best retinopathy. It varies from best vitelliform macular dystrophy to retinitis pigmentosa. It's caused by mutation in the BEST1 gene, and when the patient comes with this type of classical picture, we don't tend to miss it. It's very easy to say that there is an egg yolk appearance on the macula, and this is the patient is having BEST disease. But sometimes they can present in the later age group, maybe even at as late as the 60th or 7th decade. That's the time we might get confused with other diagnoses like CNVM in these patients. Usually these have bilateral representations, but sometimes the stage of presentation may be as pseudohypopion or a subretinal or sub-RP fibrosis or as RP atrophy, and even as complication as a CNVM. These are the various stages. I don't want to go into the details. The most common loss of vision in these patients are due to the CNVM. Otherwise, they all have an ambulatory vision. They are able to carry out their day-to-day activities without much of issues. There is an important role of other investigative modalities in these patients, like all other conditions we had discussed previously. FFA and OCT plays an important role to diagnose when there is a confusion in the when you see the clinical picture and it is not fitting into any of the diagnosis. And we can confuse these cases sometimes even with PD or a classic CNVM, because that, like the previous speaker has shown you, the one case which had presented with that fibrotic pillar, so that you can mistake it for a CNVM complex. So these are the few pictures of BEST disease which we had seen. In that the importance of FFA I am saying, because when you do the angiography, it shows a hyper fluorescence, and in the center you can have this because of the pooling of the dye which is happening there, and because of the window defect, because RP atrophy is there, and that is causing the window defect. And this is the FAF of the same patient, which is showing hyper autofluorescence in the periphery, and there will be a hypo in the center. Again, the peripheral hyperfluorescence is due to the lipofuscin deposits which is happening in the peripheral area, and the center hypo is due to the RP atrophy. Yes, EOG comes to play when we have a suspicion in the diagnosis. Otherwise, usually clinically and with these modalities, we will be able to come to a correct diagnosis. This is another patient who had presented in the vitilo-eruptive stage. You can see a scarring in the left eye, and this is the FAF again, the peripheral area showing hyper autofluorescence, and you can see because of the atrophy, the scarring, there is a center hyperfluorescent in this patient. And this is the same patient's OCT. Like in this, you can see that the elevated lesion, and sometimes we can take this for a CNVM complex. This is another patient who's came to us in the atrophic stage. Again, you can take it as a dry AMD in the advanced stage, and you can see this area, there is a gross RP atrophy which is more prominent in the left eye than the right eye, and is causing foveal thinning and the scarring on the RP complex, and there is loss of the photoreceptors also. So these patients can have very reduced vision. What are the differential diagnoses that can come to you when you see this patient, these patients at the first time? One is subretinal granuloma. Usually these patients have other features of inflammation, so that unlikely we tend to miss or mistake this with the granulomas. The other one is, as I already spoken, wet age-related macular degeneration. That is in the advanced stage when there is a scarring. But the scarring which is happening, that is the disciform scarring in ARMD, that causes, it has an irregular margin, and then it is not that typical yellow and a smooth appearance as we see in the BEST disease. This is another thing, acute exudative vitelliform maculopathy. This is reported in a few patients now, and you can see that there are multiple lesions, and which is seen in the OCT also. This is seen as a component of a paraneoplastic syndrome, and then patients who have taken chemotherapy, they have presented with this. Then fundus flavimaculatus, and sometimes even large dehemoglobinized subretinal hemorrhage can be mistaken for a Best disease. But usually that is unilateral, whereas Best disease have bilateral presentation. CSR and adult onset vitelliform macular dystrophies are to be kept in mind. A word about adult onset foveal vitelliform dystrophies is as by the GAS, and these also have similar pictures. These are a few cases. This was a 51-year-old male. He came with blurring of vision, and his vision was 20 by 20 in the right eye and 20 by 22 in the left eye. Anterior segment was unremarkable. And this is the fundus examination. You can see there were some few drusen's were there, and subretinal deposits was seen in the fundus picture. And the FAF, it was showing hyperautofluorescence in the fovea, and FFA was not showing much of a leakage, mild window defect was there. And this is the OCT, it's showing a subfoveal lesion in both the eyes, and which was more in the subretinal location. I followed up this patient. I'm seeing him last 2 years, and there is not much deterioration in the vision, and no changes in the fundus picture. This is another case. Again, vision is 6 by 6, and he has a small lesion. When you look closely at the fovea, you can see that. And in the left eye, there is an atrophy surrounded by yellow ring. Again, OCT was showing RP irregularities, and I've not given him any treatment, and he's on regular follow-up. This is similar case. He has vision of 20 by 25, and again the macula is showing some vitelliform changes with RP atrophy, and this is the OCT pictures, an old image, and he has vitelliform changes with good preservance of his vision. There is no definite management of these patients. We have to screen them for development of CNVM, and if they develop, then anti-VEGFs can be given. These are the various complications, varies from sub-RP atrophy to fibrosis to CNVM, or sometime foveal thinning and macular holes can develop. To conclude, multimodal imaging play an important role in these patients, because sometimes just by an angiography or OCT we may not be able to reach a definitive diagnosis. OCTA plays a major role in such patients, and we need to keep them on regular follow-up, so that if secondary complications like a CNVM occurs, we need to intervene. Thank you for your patient hearing.
Thank you, ma'am. And now I'd like to welcome our esteemed speaker today, Dr. Colonel Sanjay Kumar Mishra. He is the head of the department at Army Hospital Research and Referral at Delhi Cant. And I'd like to bring to your notice that he is the most awarded Army officer till date by the President and all the chiefs. Sir will be speaking today about a very burning topic, polypoidal choroidal vasculopathy. Some of the mimickers that we like to present about the typical classical choroidal neovascular membranes that are present in our day-to-day practice. And what will you change in your practice after you see all this data here?
Now, to the inflammatory CNVM, I'll surely inject antivirals.
Yes.
And I wanted to know if you are injecting two things at a time. Do you do paracentesis?
Okay, that is a very interesting concept, that if you are going to use something like Ozurdex, then the 22 gauge entry of the Ozurdex usually leads to the formation of a blip most of the time, unless they come up with the 30 gauge that they are seeing right now. So when you are injecting the anti-VEGF first, it's a slightly tense eye. The moment you now make the 22 gauge entry of the Ozurdex, the blip forms automatically. If the blip is formed, you can let the eye be. Just try to touch the eye with your bud. If it is still hard, try giving a tablet of Diamox. But if you very strongly feel that yes, now this pressure is almost to the tune of 40 millimeter mercury or so, why not do a paracentesis? So it has to be a case-based thing on the table. You cannot go with a preset mind that I'll inject this case and not inject this case.
When you inject children, you have to be careful because their sclera is thin and tend to leak. So sometimes you might even have to suture that. It has happened. People have reported such the thing, though I haven't faced, though we've given in as young as 12 years old girl, I have given Osodex, but sometimes it tend to leak. And especially in vitrectomized eyes, that is another the thing. You know, again, there can be, so that you have to be careful because of this large size in the port. You know, thing. You keep them, they call them back again after 4 weeks, 6 weeks, keep them on follow-up. Then you feel there is changes happening. There is a development of SRF or something. That will give you a clue to. And usually best disease, they come in the younger age group, between 20 to 40 they present. They'll have some sort of blurring of vision and, you know, the vision will be around 660 to 618. Whereas in CN, when the scarring, that older individuals, when they come, they will have much lesser vision, you know. That way you will be able to. And as I said, no, that margins. In the CNVM of ARMD, it will be a disciform scar where the margins are very irregular. Whereas in best disease, that at least that lesion looks very well defined. You know, when you look at the thing. So in that, those are the clinical findings which you can zero down. This is because of ARMD.
I think we are ready with the presentation. Without ado, we'll start.
Thank you very much. Thank you, Pradeep. It's very nice speaking on this beautiful morning. I shall be speaking on a very fancy topic. You know, it's everybody wants to diagnose as a case of a polyportal choroidal vasculopathy. It is taken as one of the greatest mimickers. So what it has, PCV has been diagnosed as a special entity almost 2 decades ago, but more frequent and more elaborate and more confirmative diagnosis has been done with the advent of multimodal imaging almost 5 years back. It is most commonly misdiagnosed with a CSCR with fibrin. This is how a classical PCV looks like. If you see on left hand side an OCT, which will take us one scan, radial scan, you can see those double layer sign and a finger-like PED. If you see the FFA on the left side, you see a hyperfluorescence, and with the corresponding ICG, you see those polyps and the BVNs. This is a more clear picture of the FFA and the ICG. You can see on the right side the polyps, the classical polyps on ICG with the BVNs, branching vascular network. This is again a classical PCV, but if you have taken a scan, a radial scan, this may not be, you may not sometimes get a very classical PED in OCT, yet when you do the ICG, you will again see those polyps with BVNs. This is a more clear picture of the hyperfluorescence on FFA and those classical polyps and the BVNs. Sometimes even in ICG, you know, you may not get initially the polyps and the BVNs, so you have to go through the phases as late as almost 15 minutes to get for those polyps. So if you just see this initial ICG, you may sometimes miss those polyps and you tend to underdiagnose. Not every CNV or PD can be picked even on the ICG. So though you may see those classical pictures on OCT and you do this FFA and the ICGs, and you may not pick up those polyps and the BVN. So here it is, you have to go on to the other investigative modalities to diagnose. Now, this is a case of a diabetic. No, it has been diagnosed as a case of a diabetic retinopathy because the patient was diabetic for long. So he was being treated as a case of a diabetic retinopathy. But then somebody decided to do a ICG in this because of the picture on the fovea. If you see this, hyperfluorescence in the fovea, and if you see those ICG, you can see those BVN. So here is a case where it's being treated as a diabetic retinopathy, but on doing ICG, you diagnose as polyps and now being treated as a case of a PCV. This is what I was talking about when you have done this ICG, and you can see this BVNs. Sometimes when you are over enthusiastic in diagnosing PCV, you can just over diagnose a case of a simple AMD as polyps and BVN clinically also. And once you get an OCT done on this, you can just see those drusen's, just simple drusen's. And on FFA and ICG, you can see on the FFA, you can see the multiple hyperfluorescence. These are the drusen's, and on the right side, you can't see any polyps and BVNs in ICG. So you can over-diagnose sometimes or under-diagnose. So anything, not everything which hypersenescence is PCV. Especially if you're doing a ICG, you can see, and on the left side you can see hyperfluorescence. These are the leaking, or these are the drusen's. On the right side, again you can see a hyperfluorescence, hypersenescence on ICG. These are again drusen's, so sometimes are falsely labeled as polyps. The advantage of ICG over FFA is that, even with a large bleed, you can do ICG, whereas in FFA you can't do this because you will see only block fluorescence. So these are tense PD seen on ICG. The masqueraders. Now, don't miss Gofi for Pluto. This is very important. Here, if you see this, you will just label this as a case of a cystic edema. Will you not? You just see one scan and you start thinking in terms of a cystic edema. Now, the moment you change the direction of your scan, go and scan in other directions, you start seeing something different. What is that? So this is what you see an SRF and a PD. So your diagnosis has changed from a cystic edema to a case of a PCV. This is what I was talking about. This is what is the PD, and you do the OCT of the other eye. Very important in all these cases. Please do not miss examining the other eye. You sometimes over diagnose. You are very enthusiastic in diagnosing, just seeing one eye and start diagnosing. Please see the other eye. So you see the other eye, you see those PDs, then you say yes. Why there should be a cystic CME in one eye only? So then you say yes, it is different. All the cases of CME, with the new multimodal imaging coming in, you have actually changed the role of investigative modalities. Here is a case of a CSC. If you these multicolor images, it's pseudo colors, you can see those greenish tinge. These are on color imaging. These are typically seen as a case of CSC. Those yellow colors, whereas in case if there is an AMD, you will see those as a yellow color. Then you do a FAF, and there you can see those hypofluorescent ring. That is quite characteristic of CSC. Of course, once you do an angiography, you will see those hyperfluorescence, that typical ink blot pattern. And when you do the corresponding ICG, there you see this hyperfluorescence because of the leaky choroid. So what are the lessons drawn in these cases? That do not scan in just one, do not look at single B scan image. Never take out a printout. In case of any doubt, please go to the console, see all the scan yourself. You don't depend on just one scan, because you don't know the optometrist must have taken it only one scan, and then you're not able to form a diagnosis. So please go yourself, see all the images, look at the fellow eye. It's very, very important. Never diagnose a thing just looking at one eye. You have to correlate clinically. Always it is the best practice is to clinically see a patient and then correlate all your investigative modalities. And the most important is your own brain. Please, your own judgment in diagnosis any of these conditions. Would a swept source OCT help in such cases? What is the advantage of swept source OCT is that it takes a wider cut. It's a 12 millimeters cut, which can take right from the vitreous to the choroid. So in one section, you are able to see everything. So this is what is the yellow, this thing is there, you can see the depth of your choroid. So in these cases, simultaneously it takes, as I said, acquisition of images from the vitreous to the choroid, and it is easier to comment on a single scan. This is a case of inner latent cyst, So what the diagnosis comes to mind is that it could be a differential diagnosis, could be a Mactel, telangiectasia, DME, CME, BRVO, or a vitreomacular traction. So once you do a swept source OCT, you can get a scan right from the vitreous. Here you see this is what has happened as a VMT, which is pulling the retina and causing a cyst formation. Otherwise, normally it can be misdiagnosed as a Mactel. This is again in a lamellar macular hole, and on swept source OCT you can see those, and when you see the other eye, it's a normal fovea. So you diagnose a case of a lamellar macular hole. This is again an impendi full thickless macular hole. Again, sometimes being misdiagnosed as a case of a Mactel. When you see the other eye, it is normal. So that rules out Mactel. So what are the lessons drawn from VMT, VMA, or a macular hole? So look at the vitreous attachment to the retina. It's very important. The radial scans are always better than the horizontal raster scans. Must look all the B scan sections before commenting, and the fellow eye always examine, because certain conditions bilateral you tend to diagnose Mactel in one eye and then you see the other eye, it's normal. So you please rethink your diagnosis. This is what I said about swept source OCT, that it takes a 12 millimeters cut section with enhanced vitreous view mode. You can diagnose a case of a VMT straight away on a case of a swept source OCT. Sometimes fluid may not be because of the macular edema. You see this picture, you say that it's a CME. But once you do the other investigative modalities, see what happens is that you do other investigation, OCT, angio, the FAF, then you see, yes, it is a case of a foveoschisis, X-linked foveoschisis. So again, what was your diagnosis, what you think, your brain starts thinking in terms of CME, and then you end up landing as a case of a foveoschisis. Again, this is what I was talking about, the hyporeflective space. Yes, again, you must start thinking in terms of Mactel. Definitely, once you see the other eye, because even the lamellar macular hole, it can be misdiagnosed as a case of a LMH, but you see the other eye, in case of it is affected, then yes, you have to start thinking in case of as Mactel. You see this color pictures, you can see those telangiectatic vessels and bilateral involvement. So again, you just diagnose as a case of a Mactel. This is a case of a telangiectasia with you see this again, can you see this, again leaking the hyperfluorescence on FFA. This was missed out. So just as a case of Mactel, but it is associated CSC again. So what is the role of this, that you have to correlate, go step by step, do one investigation, follow up with other investigation to confirm your diagnosis. And this is the last slide. I would like to emphasize that here is a case of an exudative RD. But how did OCT help in this case? If you see the choroid, it's quite homogeneous. It's absolutely homogeneous, and there is no subretinal inflammation and no vitreous inflammation. So this is not a case of a simple exudative RD. So this was a 33 years old lady. We were able to give the picture of this. It was a case of a metastasis from adenocarcinoma. So the OCT helped us to zero on to a diagnosis. When the lady went for a PET scan, we started thinking in terms of metastasis, and yes, it was a case of a metastasis. So wherever possible, even with your Cirrus machine, OCT machine, please use EDI mode. These can sometimes help you clinching a diagnosis to make you think or think which normally you are tend to miss out. And please use your OCT hardware EDI mode whenever available. And the role of OCT angio cannot be overemphasized because it's a non-invasive. With this, you can diagnose so many things which otherwise mimics PCV. Thank you.
Thank you. Thank you so much, sir. And we will not take questions right now. We'll be saving time because of the technical glitches we faced. Now I welcome Dr. Ruchir Tiwari. He is the director of Tiwari Eye Hospital at Noida, and he is a prolific vitreoretina surgeon, and he'll be sharing his experiences with few rarer macular disorder. He is filling up for Dr. Vipin Rana from PGI, who could not be present today. Thank you so much, sir.
Yeah. Good morning, everyone. Thank you, Colonel Pradeep, for giving me this opportunity. So this is not my presentation per se. This is someone else's presentation, but these are very interesting cases. So, and because of want of time, I would want to rush through the cases just to show what is important in these cases. So the acknowledgements are from faculty of PGI. The first case is a 39-year-old Asian male. He presented with chief complaints of decrease in vision in his left eye for 15 days. It was insidious, gradual onset, painless, associated with metamorphopsia. Now, patient had already been treated with the intravitreal injection outside for a possible diagnosis of a CNVM in the right eye and no treatment in the left eye. So these are ultra-wide field images of the right eye. Vision is finger counting at this time. So what we see here is a whitish yellowish structure in the macular region, which is visible, and the surrounding pigmentary changes along with it. Now this is a clear-cut case of a CNVM. What is missed in this image is these black lines, which is starting from the optic disc and emanating radially outwards, and these black lines are seen elsewhere as well. And once we move to a higher imaging, we see that in the enlarged image these black lines are even more visible. So the patient does have a CNVM, there's no doubt about it. When we look at the other eye, again a similar picture is visible. Black lines emanating from the optic disc and going radially outside. The left eye also shows some pigmentary changes. So there is CNV, but the basic diagnosis changes. The patient has angioid streaks, and that is why the patient had bilateral CNV at a young age. So fundus autofluorescence shows us pigmentary changes in the posterior pole in both the eyes. Also, the peripheral drusins are now identified as a marker for angioid streaks. So patients who have peripheral drusins, they tend to have complications of angioid streaks as well. So an OCT angiogram was performed, which shows a well demarcated membrane complex in the right eye. Now all the vessels are dilated, so there's no activity there. On the other hand, in the left eye we can see that there is an active membrane complex and along with subretinal fluid. So patient had already received treatment for the right eye. It was stopped because there was no activity, but there was decrease in vision in the left eye, and the patient required anti-VEGF treatment for the left eye. After 3 monthly doses of anti-VEGF, we see that the BVN is now almost gone. There is no subretinal fluid, and the patient's vision has improved. BCV is 6.9 at this point. So the second case is a 12-year-old female patient, decreased vision in right eye, noticed 2 months back when she closed her left eye. So this happens very frequently with kids. No history of redness, pain, watering. She was diagnosed as idiopathic CNV and advised anti-VEGF injections. She did not have any systemic history. This is the fundus image from that time. BCV again is counting finger at 1 meter. The fundus picture shows a whitish lesion just superior to the fovea. Now this is a subretinal lesion. Blood vessels can be seen going above it, and then there is a lot of pigmentary change in the foveal region. Left eye is absolutely perfect, vision is 6.6. So a swept source OCT was performed, which showed something in the choroid. Now this is not a very normal picture. This is a well demarcated structure which is visible in the choroid, and if you look temporal or nasal to it, you can see the normal vascular structures of the choroid, but something has happened in this area, and there is subretinal hyperreflective material in the subretinal region. So two distinct structures were visible. One is these lamellar lines, the white lines that are visible, they're stacked as a lamella, and second were these black channel like structures. So this was not a normal picture, this was not a normal presentation. A vertical scan through the lesion showed a whitish membrane complex which was already there. The foveal region was looking more or less okay. So this main membrane complex was actually away from the fovea. These are offset scans. But the choroid beneath was not normal. As we go along the scans, we see that a large area is being encompassed by this entire thing, by this entire complex, the membrane complex and the other structure. So on performing an angiogram, what we found was hypofluorescence in the early phases, then a membrane complex appearing, and a patchy hyperfluorescence later on. The other eye was absolutely normal. A swept OCT revealed a branch vascular network complex. An ultrasound was done to localize through that lesion to see what was happening, and what we found were supramaximal spikes going off the charts, which suggested the diagnosis of a choroidal osteoma. So the patient had a choroidal osteoma, she had a CNVM. So in a 12-year-old kid, if you have a CNVM, it cannot be idiopathic therapy. It is very unlikely to be idiopathic, so we have to look for other causes. So problem, and there are a lot of DDs, so depending upon the age of the patient, depending upon the clinical picture, and using multimodality imaging, it becomes easy to distinguish between these two entities. Now CNV had to be treated, so patient was given intravitreal ranibizumab. Now this case presents a twofold problem. There is a CNVM which is easy to treat, multiple repeated anti-VEGF injections, but the other problem was the choroidal osteoma component, which if reaches the fovea can lead to further vision loss. So for that, ablative laser photocoagulation or photodynamic therapy can be tried. So again, as I explained, it's a twofold problem, and we need to treat both the CNV and the basic underlying problem in this particular case. So choroidal, these are some publications regarding what the picture of the choroidal osteoma was. So there are two separate entities that were visible. The white lines were actually the bony lamellae, along with vascular channels which appeared hyporeflective on the OCT. So these black regions are the vascular lamellae between the bony structures, between the hyperreflective stacked lines that are visible on the OCT. And the third case is a 50-year-old male. He presented with chief complaints of decrease in vision, bilateral, right more than left, insidious gradual onset, painless, and there was some metamorphopsia. There was no history of floaters, flashes, glare or double vision, no significant past history, non-smoker. Patient had received 2 anti-VEGF injections which did not show any response. So this, the BCVA was 6/24 in the right eye, 6/12 in the left eye. The anterior segment of that was absolutely normal. The posterior segment showed this. Now, this is the right eye, this is the left eye. I think after Colonel Raji's presentation, things would become much clear what we are going to talk about here. So, 2 DDs as can come to our mind. One is AOFVD, adult onset foveomacular vitelliform degeneration, or a CNVM. Again, autofluorescence showed hyperreflective, hyperautofluorescent dots in the parafoveal region. Left eye disease is not that prominent in right now, and the OCT shows us neurosensitive detachment, lot of Schrem, but there's no membrane complex that is visible, at least in the OCT right now, even in the right eye or in the left eye. So this is the left eye where the disease has just started to come up. So angiography was done, which showed delayed pooling of dye and hyperreflective and these hyperfluorescent dots. Left eye, it's a very early disease as of now, so only few areas of patchy hyperfluorescence is visible. In the later phases, it encompasses a little more area compared to the initial frames. OCT angiography did not reveal any membrane complex. And if you do an EOG, you get to the diagnosis of AOFVD. So no treatment of anti-VEGF. Patients, best part is that the patient's visual acuity remains more or less stable in these cases, and only observation is required. So not all membranes are, not all the things that look like membranes are actually membranes. Uh, I think a lot has been discussed about AOFET. We may not go through these slides. Thank you.
I am extremely thankful to Dr. Ruchi for this presentation and all my fellow colleagues. For the sake of time, are the next session people here? Not yet. So then, sir is here. Okay. So in case there is time, the speakers can let us know. Then we can take a couple of questions, quick questions, please. Okay. We have been informed to close the session now. Yes, please. Thank you.
Thank you so much.